So in this second recording, we'll look at drugs of the central nervous system. So as you can see here, the central nervous system is much more complex than the peripheral nervous system, basically because there's a lot more compounds, neurotransmitters that act as compounds in the central nervous system, and also the central nervous system is very, very complex. So what we're going to do is we're going to have an overview of drugs that affect the central nervous system, and then we're going to look at a few different conditions that drugs are currently used to treat. So just an overview, drugs of the central nervous system are agents that work on the central nervous system. And so the central nervous system includes the neurons in the brain as well as in the spinal cord. You can see here the medical uses and non-medical uses. One of the big things with drugs that work in the central nervous system is they have to cross the blood-brain barrier. So in the picture down below, what you can see here is that lipid-soluble drugs easily cross the capillary, whereas hydrophilic drugs can't actually go through the tight junctions. They need specialized transport systems for it to actually leave the capillaries to enter into the brain. This mechanisms over here basically works to stop toxins from entering the CNS, but also, as you can imagine, blocks entry of drugs, especially hydrophilic ones, into the brain. Now, in terms of these drugs, there's not full understanding on how the drug actually works to affect the brain. So that's one thing. The second thing is that mental health is a very, very complex issue, right? So it's not an organic, most of the time it's not an organic disease. You can't get an MRI or a CT scan or an X-ray and see that there's something going on in the brain. And so it's a functional disorder, right? And the third thing is that there's the lack of adequate animal models of mental illness. So, when you think about some mental illness like depression, bipolar disorder, schizophrenia, it's very hard to actually develop an animal model that mimics what goes on in the human brain. Fourth issue is that you can't really use mentally healthy individuals as subjects. And so what happens overall is the development of psychotherapeutic drugs tend to be about small advances, tend to be about accidental discoveries. So maybe a drug is used for something else, and then they find out that it helps with it helps psychotherapeutically in some way. All right, so it's small advances versus major therapeutic breakthroughs. One of the big things with drugs in the CNS is that a lot of the time what happens is the neurons in the central nervous system have to go through an adaptation process. And for the CNS neurons to go through an adaptation process, the drug needs to be there for a longish period of time. And we're talking about 2 or 3 weeks or more. Right? So sometimes there are different effects when drug is taken over a long period of time versus what happens when the drug is first used. So one of the things that can happen is that the therapeutic effects can increase over time as the central nervous system basically modifies itself in response to prolonged drug exposure. But what this means is that because the CNS has adapted itself or modified itself to prolonged exposure, it means that in some cases you cannot actually stop the use of the drug abruptly, right? Because the CNS has actually changed to adapt, and so when the drug is withdrawn suddenly, you can have rebound effects, you can have dependent effects, and you can get a withdrawal or abstinence syndrome. So that's what this is talking about. The other thing is that some of the side effects that are associated with the drug actually decrease over time, right? So an example here is morphine. So morphine is often used as a pain relief, and morphine also causes nausea fairly early on. However, if a person is taking morphine for a prolonged period of time, what happens is the feeling of nausea diminishes, but the pain relief effects of morphine will still be there. All right, so we're going to talk about tolerance and physical dependence in more detail as we go along. So one of the first conditions that we're going to talk about is Alzheimer's disease. The main thing to remember with this, you can read this as much as I can, is that in people with Alzheimer's disease and people with moderate to severe Alzheimer's disease, what happens is the amount of acetylcholine in the brain goes down. Sometimes it goes down so that it's only 10% of normal, right? And so that's what 90% below normal is. Now, the other thing with this is that the neurons can actually die off. So something happens that is neurotoxic, and that kills the neurons in the CNS that are affected in Alzheimer's disease. So basically, the drugs that are used to manage Alzheimer's disease actually prolong the effect of acetylcholine, what little there is, and also inhibits neurotoxicity. All right, so we're going to look at that in the next slide. So in this slide, what you see here is you see that the goals of Alzheimer's disease work to improve treatments, symptoms, and reverse cognitive decline. None of these drugs actually work to cure Alzheimer's or to actually reverse the degeneration of the neurons or to increase the production of acetylcholine, but what happens is it actually improves the symptoms. One of the things to actually remember is that the therapeutic benefits are fairly small, right? They're statistically significant, but clinically marginal. So in some textbook, it says that it's similar to taking a weight loss product for 6 months and then losing only half a pound, losing only 110 grams, right? So that's not really much benefit after that long period of time. So because it's marginally beneficial, therapeutically beneficial, it's not recommended for all patients. So again, you got to actually see whether it's worthwhile. So the main class of drugs that are used to actually manage Alzheimer's disease are called cholinesterase inhibitor. So remember, cholinesterase is an enzyme, and what cholinesterase do, so in the diagram, cholinesterase is referred to as ACHE. So this is cholinesterase over here. So what happens is cholinesterase breaks down acetylcholine into its components of acetate and choline. And you can see here choline is then recycled to make more acetylcholine. So left to its own devices, what happens is acetylcholine only stays in the synapse for a very brief period of time, right? And after a brief period of time, it's rapidly broken down by the acetylcholinesterase enzyme. And so one of the drugs that actually manage Alzheimer's is to actually inhibit that. So if you inhibit acetylcholinesterase, what happens is that the levels of acetylcholine in the synapse increases, right? It's not that the neurons are making more acetylcholine, it's just that acetylcholine is not broken down as quickly. And so it means that it's like the person actually has more acetylcholine in the synapse, and it basically helps with symptom management. Okay, now one of the things is that it has cholinergic side effects, right? So it basically can cause bronchoconstriction, can cause a slow heart rate, can cause fainting, falls, and fall-related fractures. Now remember as well that acetylcholine is a neurotransmitter in the peripheral nervous system, specifically in the parasympathetic nervous system. So it basically also speeds up various aspects of the digestive function. So it can cause diarrhea, can cause nausea and vomiting, can cause weight loss, and if that's severe enough, it can also cause anorexia. All right, so that's the main class of drugs that is used to manage Alzheimer's disease. Another class of drug is the NMDA receptor antagonist, memantine. And what this does is it basically, so NMDA is one of the receptors that glutamate binds to. And what happens is glutamate is considered neurotoxic. Right? So again, if you actually inhibit glutamate binding to the receptor, you basically reduce the neurotoxicity, and it might actually slow down the rate of neuronal cell death. All right, so that's also another strategy for managing Alzheimer's disease. All right, so you've got here just the adverse effect related to the antagonism effect of the NMDA receptors. And then also with people with Alzheimer's, sometimes they exhibit neuropsychiatric symptoms. And so these are just some drugs that are used to actually manage those symptoms. And again, very modest benefits, slightly increased mortality. So you need to actually do a cost-benefit analysis in terms of therapeutic benefits versus the potential for harm. Now that was quick and easy. Next one is epilepsy. So you see here just a brief overview of what epilepsy is. So epilepsy, in some way or shape or form, is usually associated with excessive excitability of neurons in a part of the CNS, right? So you've got a group of hyperexcitable neurons, and that group of hyperexcitable neurons is called a focus or a foci, right? So again, the drugs that work to actually manage epilepsy are drugs that actually reduce that hyperexcitability, or basically reduce the chance of neurons firing or generating an action potential. Right, so we're going to look at some strategies in which we can actually reduce the hyperexcitability and reduce the chance of neurons actually generating an action potential and having an effect. So here's just a strategy and some goals for anti-epileptic drugs. So basically, goals of treatment: reduce seizures to a level that the patient lives as normal a life as possible. And so with some of the drugs, they have fairly severe side effects. So again, you want to balance the therapeutic benefits with the potential for harmful side effects. All right, and so what you want to do is you want to decrease the hyperexcitability of the neurons within the seizure focus, and you want to make sure that the hyperexcitability doesn't actually spread to other areas of the brain. So mechanism of action, I've actually included this diagram over here just to show you or to remind you of the first two. All right, so action potentials are generated or transferred from neuron to neuron when sodium enters in. So you see sodium and potassium are involved in the generation and propagation of an action potential. And so what you see here is sodium ions have to go into the axon in order to propagate that action potential. So if you want to decrease the risk of action potential going down the axon, what you want to do is you want to decrease the influx of sodium into the nerve, right? At the end, at the axon terminal, what you can see here is you've got this voltage-gated ion channels, voltage-gated calcium channels, which when it's open, and calcium goes in, and when calcium goes in, what happens is these vesicles that have stored neurotransmitters fuse with a membrane, and the neurotransmitters are released. And so again, if you actually stop that, it basically stops the neurotransmitter being released. So again, it decreases the chance of the action potential actually being generated in the postsynaptic cell. Now, the other thing is you've got glutamate, two other neurotransmitters, glutamate and GABA. So glutamate is an excitatory neurotransmitter, right? So when glutamate is released, it actually causes excitation. And so what you want to do, another strategy, is to block that excitation. All right? On the other hand, GABA, gamma-aminobutyric acid, is an inhibitory neurotransmitter. So when GABA is released and GABA binds to its receptor, it actually inhibits what's going on in the postsynaptic cell. All right, so it actually is an inhibitory neurotransmitter. So what you want to do is you want to increase the effect of GABA and you want to decrease the effect of glutamate. Now these four different strategies will actually decrease the hyperexcitability of those neurons in the seizure focus. So if you look over here, anti-epileptic drug, again, one of the most common mechanism of action is they basically block the sodium channels in and around the seizure focus, right? So phenytoin, carbamazepine, and valproic acid all do that. Valproic acid also reduces calcium entering into the synaptic terminal, axon terminal, and it also increases the inhibitory effects of GABA, right? Phenobarbital works by increasing the inhibitory effect of GABA, and we'll look at that later on. So one of the therapeutic uses, the common therapeutic uses for all four drugs is on epilepsy, and a secondary use for carbamazepine and valproic acid is bipolar disorder. Now what you see over here is that the adverse effects of these drugs, there's some common ones, right? So you've got neurological effects across the board, and you've also got some central nervous system effects, sedation and cognitive impairment. But what I want you to focus on is CNS depression. So what I want you to focus on is the commonality between all these four drugs. And you can see here that dilantin is the drug of choice. All right. In terms of drug interaction, what happens is it can decrease the effectiveness of oral contraceptives, warfarin, and glucocorticoids. And again, oral contraceptives and warfarin is also mentioned in two of the other drugs. All right, so I'm not going to go into how they do it and why the drug interactions happen, just that they do. So really the important thing for this is to actually know the mechanism of action of each of these four drugs. Now, phenytoin, as I said, is a drug of choice, but there are some challenges with phenytoin. So the first challenge is that there's a very, very narrow therapeutic range. So the therapeutic range of phenytoin is 10 to 20 micrograms per mil, right? So it's got a very, very narrow therapeutic range. And so as it goes beyond, above 20 micrograms per mil, it actually reaches into toxic levels, and it needs to reach at least 10 micrograms per mil before there's any effect of it. All right. So that's one thing. So most drugs have a fairly linear range, dose response range, but phenytoin has a very, very narrow window. The other thing with phenytoin is that there's varied oral absorption. So if you look at this diagram on the right, there are 5 patients over here, and you can see here at a dose of 1 millimole, patient number 2, the levels of phenytoin are within the therapeutic range, whereas for patient number 1, it's within toxic range, right? And patient number 3, 4, and 5 at 1 millimole is not even within the therapeutic range. It's way below the minimum effective concentration, right? And you can see at a dose of 3 millimole, Patient number 4, well within the therapeutic range. Patient number 5, below minimum effective concentration, and it's way in the toxic dose range of patients 1, 2, and 3. So it's really very hard to actually keep it's very hard to give a standard dose, and so you have to have individualized dosing, right? So it's highly individualized because the daily dose required varies greatly between patients. All right, so patient number 1, the daily dose would probably be anywhere under 1 and between 0.5 and 1, whereas patient number 5, the daily dose that keeps it within therapeutic range is probably somewhere between 3.5 to about 4.2, right? Anything above 4.2-ish will actually make the dose go into the toxic range. So you need to actually monitor the serum levels because of this, and this is called a low therapeutic index, right? Where you have a small therapeutic range, anything above hits the toxic range, and anything below is below the minimum effective concentration. Next disorder is muscle spasm and spasticity. So what happens over here is that spasticity is movement disorders that originate within the central nervous system. So some movement disorders are listed here. Multiple sclerosis, spinal cord injury, and cerebral palsy is all within the central nervous system. Whereas muscle spasms basically is voluntary contraction of muscle or muscle group. And it's can be localized skeletal muscle injury, or can be caused by epilepsy, or can be caused by low levels of calcemia. So again, what we want to do here is we want to, with the spasticity, is what we want to reduce the excitability of those neurons, right? That lead to the spasm. So if you decrease the neuronal excitability, you decrease the muscle spasm, right? So 3 drugs. The first one is baclofen. Baclofen works as a GABA agonist. So as we saw before, GABA is an inhibitory neurotransmitter, so it lowers excitability, right? Diazepam also works around GABA, so it mimics the action of GABA. So again, it decreases the excitability. And you can see over here that sometimes excitability is decreased so much that sedation kicks in. And then another one is dantrolene. So dantrolene acts directly on the skeletal muscle, and what dantrolene does is it inhibits calcium release. So calcium needs to be released into the cytoplasm for skeletal muscle contraction to happen. So if you don't have calcium release, you don't have skeletal muscle contraction, right? And that it decreases the muscle spasms. So again, the main important thing is the mechanism of action for these 3 drugs and how they work. Next one is local anesthetics. So local anesthetics basically work by blocking sodium channels. And when you block sodium channels, you block impulse conduction along the axon. So you have the axon over here. The axon over here, and what happens is when action potential is propagated, it involves sodium going into the axon. All right, so when a local anesthetic is given, the neurons that are affected are the ones that are located near the site of injection or administration. So it does not cause generalized depression of the nervous system unless too much is administered. So if too much is administered, it actually enters into the systemic nervous system and then becomes a systemic circulation and can act to depress axonal conduction. All right, so time course of anesthesia, it needs to actually enter the axon membrane. So it depends on the size, liposolubility, and degree of ionization of the drug, because it needs to actually penetrate the axon membrane. And then termination of local anesthesia depends on how much blood actually flows through that region, because it gets terminated when the blood basically carries it away. The blood flow carries it away. And so what you want here is you want to basically inhibit blood flow or to slow down blood flow in that region. And so sometimes local anesthetics are given with vasoconstrictors. So epinephrine is one of the things that is often given together with local anesthetics. And what happens is it causes vasoconstriction in that local area of the local anesthetic. So it decreases local blood flow, delays systemic absorption, and it also means that the anesthetic basically stays in that area for much longer, and it prolongs the effects of the anesthetic, right? And as long as it's contained within a local area, there's a reduction in the toxicity, because the toxicity is usually because it has gone into the systemic circulation and to other parts of the bodies, including the central nervous system. So you see here adverse effects. If you look at the adverse effects over here, most of it is due to the local anesthetic escaping the local area, entering into the systemic circulation, and causing effects elsewhere. So in the CNS, what happens is you have a brief period of excitation followed by a depression, because it blocks the axonal conduction along the CNS neurons. In the heart, it can cause an AV heart block. It can cause reduction in heart rate, reduction in contractile force, and then the heart can basically stop, because the conduction pathway along the heart has been inhibited by the local anesthetic, and it can also relax the blood vessels and cause hypotension. So you can see here, the other thing is if those vasoconstrictors, epinephrine, is absorbed, it can cause systemic toxicity. So it can cause, again, effects on the heart, effects on the blood vessels, and effects on the brain. Allergic reactions can be seen with some local anesthetics, but not often. So just some application guidelines: apply the smallest amount needed, avoid application to large areas or to broken and irritated skin, because what happens is it can increase the absorption and therefore cause systemic toxicity. Avoid strenuous exercise, wrapping the site, or heating the site, because what happens is all those can increase blood flow to that area and therefore increase the absorption of the local anesthetic, so that it can actually cause potentially adverse effects. Last section has to do with opioids. So again, these are just some terms that are commonly used. Endogenous opioid peptides are peptides that are produced by the body that acts on the same receptors as opioids do. So three main classes of opioid receptors. Mu receptors are the ones that are involved with analgesia, respiratory depression, euphoria, sedation, physical dependence, right? Kappa receptors play a part in some of those. And then delta receptors we won't actually talk about. So just some uses of opioids in specific settings are actually listed there. They're usually used as an analgesic. Opioid agonists that are used commonly activate the mu and the kappa receptors. And so what it does is it actually relieves pain without affecting other senses or causing loss of consciousness at a therapeutic dose, right? However, opioid agonists can cause euphoria if it's given in the absence of pain, right? And so there's a high liability for abuse. When opioids are given orally, what happens is some of the drug is metabolized by the liver before it gets into the systemic circulation. So this is first pass effect. And so oral doses must be larger than parenteral doses, IV doses, in order to produce equivalent results. These are just some strong opioid agonists, and then these are moderate to strong opioid agonists, right? So the moderate to strong opioid agonists produce less analgesia and less respiratory depression, with somewhat lower potential for abuse. So you see over here codeine. 10% of codeine is usually converted to morphine in the liver, and it's used both as an analgesic as well as a cough suppressant. Now, I did say that moderate to strong opioid agonists have got somewhat lower potential for abuse, but there's always a way, right? So Oxycontin was actually reformulated in 2010 to make it harder for people to actually crush and snort and inject them. So they just reformulated, so it was more difficult to do that. All right, and then hydrocodone is widely prescribed in the U.S., and it's often combined with another analgesic, aspirin, acetaminophen, or ibuprofen. Morphine we're going to look at. So in terms of morphine, it can be administered via different routes, right? So orally, intramuscular, and IV, subcutaneous, epidural, intrathecal. So they're all the different ways. It's not very lipid soluble, so it doesn't cross the blood-brain barrier easily. So only a small amount of morphine actually reaches the target site in the central nervous system, in the brain and in the spinal cord. Just some precautions when administering morphine, just that it needs to be used with caution with people with decreased respiratory reserve, because what happens is one of the adverse effects of morphine is that it causes respiratory depression. Has to be used with caution during pregnancy, labor and delivery, and in nursing mothers, because what happens is that the blood-brain barrier of fetuses and neonates is fairly leaky relative to the adult brain, and so what happens is more morphine actually enters into the brain, and it runs the risk of respiratory depression that much more. So it shouldn't be decreased respiratory depression, it should just be respiratory depression. Head injury, again, can cause effects in the CNS, so you need to be careful when morphine is given to that. And again, as I said, in infants and neonates, the blood-brain barrier is leaky, so you need smaller doses in order to actually have a therapeutic effect. And the smaller doses also prevents adverse effects from happening. So some drug interactions are listed here, and we'll look at that more as we go along in the next few weeks, right? So again, CNS depressant, so you don't want to take morphine with another CNS depressant, because that can exacerbate the depression of the central nervous system, and so on. So what you can see here is you can see a whole list of adverse effects, right? So again, one of the big things is that it can be open for abuse, right? And there are a classic triad of overdose symptoms, so coma, respiratory depression, and pinpoint pupils. And you can see here the pinpoint pupils are listed all the way down 14, pupillary constriction, 2 pinpoint size at toxic doses. Right, and respiratory depression is also listed over here, and the coma is due to the respiration depressing so much that there's not enough oxygen actually getting into the brain. All right, and then the list of adverse effects are just listed here so that you can actually see. The other thing to note is that some of these adverse effects are only adverse because we don't want them. But really, codeine, which is another opioid agonist, is used as an antitussive, is used to suppress coughing. And also another type of mu agonist, I wouldn't call it an opioid, is loperamide. And what that does is it actually promotes constipation, and so that's given in instances of diarrhea to actually firm up the stool so that the diarrhea stops. So again, sometimes the adverse effects are actually therapeutic effects depending on why it was given. Nursing implications on opioid drugs, you can see over here, the first thing is that a pain assessment needs to be done before administration of the drug, as well as after, right? Before taking the drug and 1 hour after. So again, pain location, characteristics, so on a scale of 0 to 10, where's your pain located? How long have you had it for? And what have you done anything to actually improve or worsen the pain? All right. And then once that's done, again, you need to actually have a dosage schedule and doses, and then it needs to accommodate individual variation, usually given on a fixed schedule. Once the opioid is given, you need to monitor vital signs. Identify high-risk patients, avoid withdrawal, like sudden withdrawal, minimize fears about physical dependence and addiction, and then also teach about the side effects. So sedation, constipation, dry mouth, and nausea are some of the adverse effects. So over here you've got 5 different definitions. So the first one is tolerance. Tolerance is when you need to actually give a higher dose of the drug to actually obtain the same therapeutic response, right? So tolerance occurs with analgesia, euphoria, sedation, and respiratory depression. So again, higher as time goes on, if a person is taking morphine chronically, they would actually need to take a higher dose to get the same amount of pain relief. Physical dependence is one where an abstinence syndrome, which is the next term listed, an abstinence syndrome will occur if the drug is stopped very, very suddenly, right? So again, it's usually physical dependence usually doesn't develop for up to 2 weeks. It usually occurs with prolonged use. Okay, abstinence syndrome is basically withdrawal symptoms, and with morphine withdrawal, it's unpleasant but not lethal. So the abstinence syndrome can last about a week or just a week and a half if it's not treated. And then abuse and addiction are identified over here. So one of the questions that this whole thing brings up is what happens when a person has too much morphine or too much opioid in their system. And it's a good thing that there are opioid antagonists that exist, and what these opioid antagonists do is they block the effect at the mu and kappa opioid receptors, right? So what happens is it basically blocks the therapeutic effects, so analgesic, but it also blocks any of the other effects caused by opioid agonist, right? So there are 3 listed over here, and you can see here that that naloxone or Narcan is used frequently to actually reverse opioid overdose, to reverse opioid effects when given post-operatively, and to reverse respiratory depression that can be seen in newborns. Naltrexone is used to manage opioid addiction and abuse, right? So prevents euphoria if the abuser takes an opioid, but does not prevent craving for opioids, right? And methyl naltrexone is used to treat opioid-induced constipation. Now, I know that this is a lot, and I hope that you've taken some things in, but I'll see you again next week. Thanks.